targeted therapy, even in the, not for the only step 4 or 5 patient, even for the 2 and 3 patient as well. Yeah. And I mean,
There was a comment.
yeah, now we're talking about the personalized, yeah. Now we are talking about the personalized medicine, I mean, we are doing the phenotyping even, and the endotype. And those all studies for the 4 or 5 or the, I mean, uncontrolled asthma patient. Do you think that it can also applicable for the mild to moderate asthma patient?
Biologic treatment has an individualized treatment according to phenotypes, would, in my opinion, benefit every patient, but cost and side effect is of great negative impact. So weighing benefit and risk, stepping through the asthma guidelines would rather have a better result. So I don't think mild asthma would be qualified for such expensive and a medication that would have a side effect. So thank you.
No. So thank you so much, Dr. Anohan. Great. So we'll move to the next speaker. So there will be some modification in the program. So the last presentation will be the now, and Dr. Sami will give his presentation at the late. So the next speaker is me. So I will talk about. My name is Dr. Adel Harbi. I'm from Prince Sultan Military Medical City. I'm a pediatric pulmonologist and sleep physician, member of SINA, as well as head of Pediatric Pulmonary Association. So my talk is about nebulized corticosteroids in pediatric asthma. I will show you some evidence. In the past, we've been trying to advocate for using inhaled therapy in terms of meter dose, road spacer, which tend to be a little bit difficult, especially when we are dealing with a younger age preschool ager, which really challenge sometimes. So we'll explore some of the data in terms of which type of medication we are going to do. So the outline will try to see, is it advisable to treat asthmatic child, especially before the age of 5, early, or shall we wait? There are a lot of patients actually when they come to our clinics, they are a little bit late. And when we ask the parents, and sometimes unfortunately physicians, they will say, let's wait. It's not good to start treatment early because, ta'awud, dependence, demand, will are those false beliefs in the community. So we will explore that. And then what type of therapy that is advisable to start in those children, especially the younger the age. And then is it inhaled versus oral? Is it nebulized versus inhalers? And then we'll put some particular emphasis on asthmatic children less than the age of 5 in terms of burden and solutions at the emergency visits, as well as inpatients. So when you look to the recommendations, either from SINA or from GINA, it's very clear that both of them, they recommend inhaled corticosteroids as the preferable initial controller treatment for the childhood asthma. Asthmatic children, when they come, we need to control them rather than to relieve the symptoms. And there are a lot of misbeliefs in the community that let's treat symptoms rather than to treat the disease. i.e., treat the cough by cough syrup, treat the spasm by giving like other medications or oral solutions, which not really of a beneficial. So the recommendation is to control rather than to treat the acute asthma. And you are familiar about this STEPS approach from either from Gina or from Sina. And the other recommendation that to achieve the control, you have to look for a lowest dose of inhaled of steroid that to achieve the control. So these are the recommendation of the lower dose of steroids to be given to children in the young age, especially below the age of 5, to achieve control. And why is that? Because we are going to put some explanation why it is important to use the lower dose to achieve the control. So why we treat them early? Why not to wait? Let them just grow up and then we'll treat. So many studies have shown that early treatment of asthmatic patients will improve and protect the lung function. So if you look carefully to this study, the early interventions to those children will give you the better improvement and protection to the lung function in terms of EV1. So the management or the starting treatment below the age of 2 is better than to delay to the age of 3, is better than to delay till the age of 5. So the early treatment, there is significant improvement, especially in terms of lung function. Again, starting treatment very early will beneficial in reducing the number of exacerbations rate or the number of recurrence. So this is early interventions versus delayed treatment, and it's very clear that the number of exacerbation is reduced when we start the treatment or when we are controlling the disease very early before the age of 5. Again, early treatment of asthma allow better achievement of asthma treatment goals. So if you look to this bars, you will see the lung function is improved, number of exercise intolerance will be reduced, as well as the other complication will be reduced. So early intervention, early treatment will improve and will protect the lung functions, will reduce number of exacerbations and attack, and also to protect patients achieving better goal of management. So what about giving oral steroids? So now we know that steroid is the mainstay of therapy in asthmatic in general, especially in children. So what about giving oral steroids? There are a lot of people, they tend to give steroids without any reasons. We see them in the clinic. Patient coming with oral steroids, systemic steroids, either injections, just to control the disease, which really is not a good habit. The minimum number of courses of the oral steroid to be given to the child, especially below the age of 5, is 4 courses. We hope that we are not reaching this stage. We hope that to control the child asthma instead of giving single dose of systemic steroid. But the allowed amount of courses, when I say course, is at least 4 days or a maximum of 4 days of oral steroids. So the allowed is only 4 courses per year. Why is that? Because the incidence of osteopenia and fractures in those babies or those children, it's high. So again, here osteopenia risk is increased, fracture is increased when we are giving 4 or more of courses of steroids orally. What about the nebulization benefits in treating pediatric asthma? So again, a nebulized inhaled corticosteroid will play a strong role against respiratory disease in pediatric patients in general. Inhalation therapy, as stated by GINA guideline, is the mainstay of management of pediatric respiratory disease. And the nebulizations only, at what stage we are shifting to the nebulized rather than in inhalers? It's an alternative, actually. It's not the recommended to give. You should try inhaler with a spacer as by the recommendation from the SINA as well as the GINA. But technically, when you deal with a child, the younger the age, the more difficult to give inhaled steroid through the inhalers with a spacer. And you will see why. Why is that? Because the younger the age, usually they are nose breather, and they have problem with the mask fitness. Usually they refuse, and we have a lot of technical issues letting the child to adopt this mask. Usually we call it the desensitization program. And also they have small tidal volume as well. There is cooperation issues, and they have to hold breathing to get benefit of inhaled medications. So usually they don't have this issues. And the main problem is crying. All of you here maybe parents, and you see how difficult to ask the child to put the mask and to put the inhalers and to hold breathe. Most of them, they are crying. So you will see crying, how much is crying affecting the positions and the delivery of drugs. So this is a child crying, and you see there is a significant reductions in the amount of the drug deposition. It's only 4% reaching the lung. This is while the child is crying. The other diagram showing a child who is sleeping, not crying, and you will see how much is the deposition is only around 22%. So there is a technical issues, and also the depositions of the drugs, the inhaled drugs, crying versus non-crying child. So there are some recommendations for the delivery of inhaled corticosteroids. Infant less than 2 years of age, nebulizer versus inhalers through the air chambers. Of course, dry powder inhaler is not recommended for those. Usually, in such age, less than 2, we prefer to give some nebulized rather than inhaler with spacers for the reasons that I have mentioned. Preschooler is a little bit challengeable, and there are some struggles. Some children, they can, you have to try to give them, but we need to put in our mind there is an alternative pathway of the nebulized therapy. School age, of course, more than 5, they are a little bit cooperative, and technically they can cooperate with you, and probably the inhaler with the device is much appropriate at those age. So nebulization is an effective alternative to meter dose with a spacer. Nebulization advantages in those age group is easy to use. It doesn't need breath holding, less errors in terms of the drug delivery, as well as can be used with other either another medications or supplemental of oxygen. Other medication, I mean, like for example, when you are dealing with another comorbidities, cystic fibrosis with an asthma or bronchiolitis versus asthma. So we need to give probably some another medications or hypertonic saline. So minimal patient corporations you need in that age group, and can be mixed with another drugs, and does not need doses to be adjusted. The efficacy of meter dose plus spacer is highly dependent on patient cooperation. So the American Society of Respiratory Therapy, they give us recommendations to use meter dose inhaler with the spacer. So we need to have this following conditions. The patient should breathe slowly after aquaticing the inhaler, and the patient should hold breathe for at least 10 seconds and then inhale. And then if you need to give another additional drug, you have to wait for 15 to 30 seconds. So you can imagine how difficult technically to apply these rules, to apply these conditions in younger age, less than, for example, 5 or 3. So it's really technically more difficult. Okay. Another problem in the technical delivery of meter dose inhaler with the spacers in decreasing the amount of the drug that delivered to the lungs. So what about delay in inhalation of the delivered drug after delivered dose? Does that affect the deposition? Does that affect the outcome? So this graph just to show you there is the delay. If there is no delay, this red bar to show you the deposition or the drug deposit in the lung. If there is no delay, it's only 30% of the drug will deposit. If there is 1 second, there is a significant reduction in the amount of the drug deposit. If there is 5 or 20 seconds delay, there will be again, more significant reduction in the drug deposition. So this is a technical problems that making us thinking in another alternative delivery system. So as an alternative here, as a solution for this, if we give more doses, so let's say we avoid this delay, let's give more doses to overcome this delay. Does that affect? Again, there is no much significant reduction or improvement in the deposition of the drug. So either if there is delay in the breathing will affect the deposition of the drug, and even if you give more doses, the deposition of the drug will be less, and there is no significant improvement. So if there is a leak, what about the face mask and the leak in those kind of younger age? It will also affect the deposition of the drug significantly, even if it is very minimum amount of leak reaching 0.4 centimeter. So now, is it dry or humidified? Some people, they will say, let's give the child with asthma will benefit from dry medications rather than humidified. So what about giving dry versus humidified inhaled therapy? So this graph also will show you that the FEV1 in asthmatic children, if you give them the drug with humidifications, the FEV1 is much improved compared with dry solution. So giving nebulized is better in terms of FEV1 improvement compared with dry powder solution in those particular patients. There are different types of nebulizer available in the market. So there is a jet nebulizer, ultrasonic nebulizers, and the mesh nebulizers techniques according to the technology. And there are different, utilization and indication for this kind of nebulizer. So anyway, I will skip this just to show you that usually if you are going to go with nebulized therapy for asthmatic children, usually we recommend the jet nebulizer for the advantages that mentioned in the slide. So the recommendation is usually jet nebulizer. Don't try to use the other ultrasonic or the mesh technology for those particular patients. So now we'll move to the managing a child with acute asthma in emergency department. You know that the burden of asthma in preschool age, as in terms of acute asthma, is very high compared with older children, and it's causing around 50% of ambulatory visits. 2 times emergency department visits is due to acute asthma exacerbation. 3 times risk of hospitalizations when they are not treated very early with an appropriate medication and an appropriate technique of delivery. Treating child with acute asthma in the age of less than 5, it depends on suppurative measures, supplemental oxygen, inhaled short-acting beta agonist, and systemic steroids. We'll go through this in details. So Gina and Sina highlights, Dr. Sami Haider, he will present the more updated highlights from Sina regarding pediatric patients. So I will just go through the technology part or the delivery system. So treating acute asthma efficiency in using a meter dose with a spacer. This is a study of around 20,000 child aged from infants to 18 who attended emergency department with asthma, with acute asthma, comparing in two parts. The first part, they compared short-acting beta agonist by using nebulized, and in the other part of the study, they compared the meter dose with spacers. So the outcome compared to both technology, there is no increase in patients' admissions or even the ICU admissions. Including that, the average length of hospital stay as well, it was not really reduced. So there is no much, either to give the inhaled or versus the nebulized one. The effect of oral corticosteroids, usually we keep this as an alternative. So the recommendation usually start to give inhaled steroid in terms of preferable meter dosed with spacer depending on the age of the child and to avoid the technical issues that we mentioned. If not, you have to give the alternative, which is the nebulized, especially for the younger age. Giving steroid as a systemic, it will not really affect the outcome. This is a study just to show that prednisolone for 4 days as a rescue. There was not really much reduction in the severity after giving systemic steroid, especially if it is associated with lower tract respiratory infection. And there was no difference in terms of cough, wheeze, trouble breathing, or interference with the activity if you give the systemic steroid compared with inhaled steroid in a proper appropriate technique and dosage. These are 700 preschool children aged from 10 to 60 months of age hospitalized for acute wheezing preceded by lower respiratory tract infections. They gave 5-day course of oral prednisolone versus placebo. The primary outcome duration of hospitalization was not significantly different between the two groups. So giving systemic steroid for even 5 days in acute state does not really affect the outcome in terms of duration of hospitalization or reductions in secondary outcomes such as use of relievers or rate of readmissions. Treating acute asthma, depending on inhaled corticosteroids, is more beneficial than the systemic steroids because it acts more rapidly. So this is a global initiative for asthma. This is GENIA when they recommend that high dose of inhaled corticosteroid given with the first. Can you go? The slide is. Sorry. Slide is moving by itself. So giving the high dose of inhaled corticosteroid in the first hour of presentation to the emergency department will reduce the need for hospitalization in those patients and relieving the acute symptoms. This is the evidence A, as well as to reduce the length of the stay in the hospital. So if you want to give in the emergency department, probably you need to give higher dose of inhaled steroids. Try to keep the systemic steroids as an alternative. Sorry. So nebulized, the guidance for nebulized inhaled corticosteroids in asthmatic exacerbation as per the GENIA in children, there are double-blind placebo-controlled studies with evidence A suggesting that in an emergency department, high dose of inhaled corticosteroid given with the first hour of presentation will reduce the need of hospitalization, as we mentioned earlier. So long-term treatment with nebulized budesonide, for example, as inhaled corticosteroid therapy, is well tolerated in infant and young children. And there is the incidence of reported diseases events was comparable between the nebulized budesonide and common asthma treatment groups in both after 52 weeks of treatment. So nebulized steroids like budesonide does not significantly affect growth velocity compared with conventional asthma therapy, because that some people they will say giving higher dose of inhaled steroid will probably affect the growth. There is no evidence behind that. Budesonide has significantly less effect on plasma cortisol level than oral steroids. This is the early morning cortisol level in both budesonide, prednisolone orally. there is no much, usually there is no much effect in terms of adverse effect on the cortisol release. So Gina is telling us important of prescribing the right treatment and duration to achieve the good asthma control. This is our strategy in treating asthmatic child. So that the role is to achieve control and to prevent child from relapse or frequent presentations to the emergency, and to participate normally and to sleep normally and to avoid such cascades of complications. So asthma management in young children, definitely early intervention is much better than late and delay in the treatment, as been shown. A type of therapy, usually controller is the advisable. We see some patients coming to the emergency or coming to the clinic. When you ask the mother, she will tell you that he is on or she is on Ventolin, for example, nebulizer or inhalers, but however, he is not on any controller, which is opposite to the strategical plan. The strategic plan, we need to keep the child on the minimum dose of inhaled steroid to achieve control without using of short-acting bronchodilators. Inhaled corticosteroid, of course, is much better than the oral corticosteroids, and here we need to avoid as much as possible giving a child systemic steroid for the reason that we mentioned. The toxicity is higher, even the beneficial effect is not really significant. And if the child fail or difficult technically to give him or to give that particular patient inhaled steroid through the advisable way, which is meter dose plus spacers, the alternative, especially in the younger age, is nebulized therapy for the reasons that we mentioned. And inhalers versus nebulizer, we mentioned this. So thank you so much. We can receive a few questions if there are questions. Yes. Yep. Yep.
Please, can I ask the maximum dose of nebulized budesonide for the children younger than 2 years of age? How much can we give per day for this patient before in the attack? How much the maximum?
Yeah, the younger age usually try to use the minimum dose. So for 500.
If the patient coming with severe asthma attack and I'm trying to escape to give oral steroid as much as I can.
Okay, so again, you start with the lower dose. So the maximum we can reach 500 microgram per day. This is the maximum for those particular patients, which if you compare to the oral steroid is much less dose than the oral steroid. So 500 is the maximum for those type of patients. Yes.
Thank you, Dr. Abel, for a nice presentation. While we're pediatricians, we always find difficulties to manage the young children, especially the long-term management of
Can you
asthma.
just close the mic?
Long-term management of asthma, like inhaled corticosteroid. Now, do you recommending nebulized steroid long-term management, especially below 5 years? Or still I have seen the latest SINA also, they are giving by special device. So what is your recommendation supporting this study?
So the recommendation, first of all, asthma in children usually is a seasonal type. So we know the season. Usually asthmatic patient, pediatric age, they come in the winter season or probably from 1 month before the winter and 1 month after. So we're talking about November to April. So these are the the months that usually asthmatic children, they are having asthma. So during this particular period of season, you have to reach the control. So you can start as per recommendation by Gina and Sina. You start with the minimum dose of inhaled steroids in terms of meter dose plus spacer. But if the child is very young and really difficult to control or technically to give, you can shift to the nebulized therapy. Of course, the nebulized at home, usually it is difficult technically again, because you need to prepare, you need higher dose, and duration of giving them the treatment is a little bit longer than the meter dose type with the spacer. But our advice is to start with inhaled plus spacer. Try to educate the parents how to give the technique, how to do the desensitization program, how to make the child, cooperative with time. In flare up, of course, recommendation is nebulized type for short period, and then you go back to the inhaler with the spacer. This is the recommendation. So instead of going into the systemic steroid, try to go through the nebulized steroid rather than systemic, and then you see the response.
Excuse me. My question is about the uses of macrolides.
Bronchiolitis.
Macrolides, yes, azithromycin. If the patient came to me, we are working in the PHT, okay? Patient came to me with exacerbations of acute asthma. There is no improvement in steroids. Should I use macrolides blindly, and as if it is the phenotype is?
Can you just take it close? You are asking about bronchiolitis.
Uses of macrolides, yes, azithromycin. I mean, azithromycin.
Okay, azithromycin.
Okay.
In asthmatic patients?
In asthmatic patient. Patient came to me and he did not improve on steroids. Okay. Should I use macrolides blindly? Yani we have no facility in primary healthcare to see the phenotype or like this.
Yeah. There is no single recommendation to use, or there is no single evidence to use antibiotic or macrolides in patients with asthma. Asthma is not an infectious cause, it is inflammatory. So the failure in achieving the control in those patients, usually it comes from either the education, the parent, they don't know exactly what is an asthma, or from the technique of delivering the medication. They are not familiar with giving the dose. So before macrolide, there is no role, first of all. But you need to dig more in the history, make sure about the education, make sure about the asthma devices, make sure about the technique. And if there is an issue in the technique, there is always an alternative pathway, alternative way, like using the nebulizer. Yeah. Yes.
Is it true that the long-term using of the inhaled corticosteroid can cause in the future sort of idiopathic avascular necrosis in the children?
If you give the appropriate dose according to the age, according to guidelines, usually there is no much effect on the future growth on those patients. The problem, if you give systemic type of steroid, that's an issue. I show you some slides about the using of more than 4 courses of systemic steroid. And we don't recommend to give the child forever on inhaled steroids. So you need to bring the child again after 3 to 4 weeks to assess the control level. And then you step up or you step down according to the asthma assessment tools that Dr. Sami will telling you soon. So it's not like to put the child on that dose of inhaled steroid and to tell him to go and then to come after. The maximum period of observation, at least 6 weeks to 12 weeks, which is 3 months, and then you need to assess. But I recommend during the winter season to assess the child every 3 weeks at least. And you can go up or down according to your level of assessment or level of control. Yes.
Thank you, Dr. Adil, for the review of the subject. Do you still, in emergency treatment of asthma, severe asthma in children, do you still start by inhaled steroid usually in this case, we start by IV steroid, go hand in hand with phentoline and ipratropium. Do you still start with inhaled steroid? Severe asthma, I'm talking.
Yes. Yes. Don't forget asthma. When we start with bronchodilator, you are just relieving symptoms. The asthma is inflammatory process, so we need to stop this inflammatory process. Steroid, the anti-inflammatory agent that's available. So the question: are we going to give inhaled steroid higher dose or systemic steroid? And if we are going to give the inhaled steroid through the higher dose, are we going to give through the meter dose with a spacer or nebulizer? This is the issue. So I have shown you some evidence that inhaled steroid in terms of nebulized in those younger age is much better than going into the systemic steroid orally. So try first, assess the response. If there is no, you can adjust because we need some agent to work at the point, at the targeted organ, which is the respiratory system. Yeah. Okay, so I think we have to move to our next speaker. It's the last presentation in this session today. It's some highlights on gene and SINA guidelines in the children's sections, which have been updated in 2019. And Dr. Sam Al-Haider is our next speaker. He's a consultant, a pediatric pulmonologist and interventional pulmonologist as well. He's working at King Faisal Specialist Hospital. He's associate professor at Al Faisal University, and he's currently executive director of training in Saudi Commission for Heart Specialties. He's going to talk about highlights from SINA 2019. Dr. Sam.
Okay, so بسم الله الرحمن الرحيم. السلام عليكم وأسعد الله مساكم جميعا. So waiting for my slide. So use this. Okay, good. Okay, so thank you, Dr. Adil, for the introduction. I think you make my life much easier after your presentation. Though the time allocated for the SINA guideline is not going to be really sufficient to take you to the full document. So actually, as I'm going to refer you in within the presentation, we have lots of resources online that you will be referred to. So as Adil mentioned, SINA guideline is one of the local national organization, has been going on for a few years. It's something really we are proud to have here. It's an organization focusing on asthma initiative. So it's a Saudi initiative for asthma in Saudi Arabia. And this is a subsidiary group coming from the Saudi Thoracic Society. So in my talk, I will be trying to go over what we have presented in this guideline in the pediatric section. So it started with the burden of asthma, as most of you, as I understand that most of you are general practitioner and maybe pediatrician or family or internist physician. Asthma represents really a major public health issue. It's among the spectrum of diseases where the general practitioner and the subspecialist has been facing commonly either in emergency setting or on long-term care for the chronic asthmatic patient. In pediatrics, it has major impact. It's a leading cause of childhood morbidity that presented with absence from school, emergency department visits, and hospitalization. And the cost of not treating asthma is way higher than asthma treatment. And this is why asthma prevention and treatment is really a priority for any healthcare system or health practitioner. There is major financial impact. More than 2 million pediatric ER visits are estimated annually in North America. 25% of hospitalization is resulted from that. In European Union, the cost of pediatric asthma alone is close to 3 billion euro per year. And this is really major impact on the healthcare system. Now, this is, I think, the most important slide in my presentation, and it will come again and again during the presentation. So if you can just capture this and come out from this presentation with this, might sound to you very basic and foundational, but it is really from year to year with every asthma guideline updates. It seems to be the golden stone and the cornerstone strategy in asthma management. So the most important thing is really to establish asthma diagnosis, and then to have a treatment plan, and then to consider patient education, and then to include action plan, and always to remember prevention, as prevention is really a very important aspect in asthma management. We will go over those elements as we go through the presentation. In terms of diagnosis of asthma in children, the message is always asthma is a clinical diagnosis. You don't need a blood work or a laboratory test, including pulmonary function test, to diagnose asthma. Asthma is a clinical diagnosis. And what we mean by that is to have the phenotypical presentation of asthma, which include recurrent and relapsing presentation of asthma symptoms, or a chronicity in asthma if it is not treated well, and looking to the features of asthma, which is basically an obstructive airway disease features, and that include wheezing, coughing, night symptoms, activity limitations, and shortness of breath. Symptoms results from airway hyperresponsiveness to various stimuli. So this is also an alarming flag for asthma diagnosis. So usually there is a relationship between an asthma presentation and the trigger, and your role as physician is to look always for what is the trigger for asthma in those patients. In terms of, as I mentioned before, the diagnosis of asthma is really challenging, especially in the young children. And every one of you will think about why asthma diagnosis is difficult in a preschooler. And the simple reason for that, because there is many mimickers in this age group representing asthma. And the most important mimicker of asthma in this age group early in life is viral infection, because we believe that bronchiolitis is an overlapping syndrome with asthma. And it really makes it difficult for a physician to make sure that what we are dealing with in this age group is really asthma or pure viral bronchiolitis, or an overlap between both of them, which can coexist together. So the message from this slide is actually to focus on something. I have seen it as a pulmonologist with many general practitioners labeling patient with reactive airway disease, the RAD. And this is actually something we should discourage everyone from use. I find this approach is like fading out from the confidence of making the diagnosis of asthma. You have really to make sure that you label the patient with asthma, or you make it clear that this is not asthma. Using those shady terms will make it really difficult, and the end result will be throwing everything: antibiotics, systemic steroid, inhalation and therapy, and even the education for the parents will be very confusing because it's not clear what you are targeting. So reactive airway disease is a physiologic term. It shouldn't be used for clinical use or for even action plan or treatment plan to be made and discussed with the family. So how we make the diagnosis, again, it's the pure clinical skills that you have to equip yourself with. So you have to go back to history and history and history. History taking is very important to delineate the presentation and the trigger factor of those patients. And so presence of atopy in those patients, presence of early sensitization, presence of family history of atopy are very important in the history taking. And whenever possible, doing spirometry for those patients will be really helpful for you, because you can document, quantify, and quantitate how much involvement of the airway obstruction is there. But again, for those of you dealing with pediatric patients, we know it is limited with their cooperation and ability to do this. And children, they vary from age to age. Some of them, they can do it in 4 to 5 years. Some of them, they cannot do it even if they are 10 years. It takes from them concentration, linguistic, and also the coach from the respiratory lab who is going to give them the instruction is also very important. Unfortunately, most of our children, they deal with second language personnel who is teaching them how to do the PFT or the spirometry. So again, it is of great use, but it is limited. Again, I see some practitioner who avoid using spirometry in older children, thinking they cannot do it. In my clinic, we can do it as low as 4 to 5 years if they are cooperative, if they have normal cognitive function, and if the respiratory therapist in our lab is able to communicate well with them. In our SINA guideline, we have a summary of clinical presentation, including physical exam and history taking, very important indicator that you have to master as a general practitioner. So again, don't focus on only labs or BFT. You have to equip yourself with the history and physical exam competency. Now, always remember there is asthma mimicker. Any reason for airway obstruction can compete with your diagnosis. And making the wrong diagnosis is really bad because you are going to give wrong medication, you are going to give wrong patient and family education. So when you have to consider asthma mimicker when you have failure to thrive, because as we know, asthma by definition should not lead to failure to thrive. If the onset is really during early infancy, this is not typical of asthma. Continuous wheezing that does not respond to bronchodilators. This is also against the diagnosis of asthma. Failure to respond to controller medication after establishing the diagnosis, getting the right dose and using the right technique in dose medication. Presence of clubbing or focal auscultation in the chest, also by definition, this is against asthma. You have to make sure that there is no other competitive differential diagnosis which can present the airway obstruction disease. The final one is the symptoms not associated with the typical triggers. So if you have symptoms for a child who never been known to have asthma with no identified trigger, you have to consider before you just sit in the chair saying it's asthma, you have to make sure that there is no other diagnosis. And in children, one of the things which is serious is foreign body. For example, if you just sit in the chair saying there is no trigger, this is the first presentation, and they have focal wheezing in one chest, this is not asthma. So always make sure that you don't overdiagnose asthma, as we are discouraging underdiagnosing asthma. Now, one of the things which has been of interest in pediatrics, and this is one of the areas where asthma is different between children and adults, is asthma phenotypes. The asthma phenotypes in children has been well characterized from many epidemiological studies in UK, Australia, and the United States. And all of them, they were roaming around the same classification with different terminology. One of the famous phenotypic classification of asthma is the Towson Children's Study, which was done early in the United States, where children were followed with asthma till they reached their adulthood age. And the end result was that from that cohort, almost more than half of them, they never wheezed and they never had asthma. And the remaining 50% of them, they have either early transient asthma, it's almost one fifth of the group, and they have it below the age of school age, less than 3 years, and then they have it, they grow out of it by the school age. And then there is those with persistent asthma, where it started early on and it continued for their adulthood, and they represent almost 1/6 of the children. And the last one is the late onset asthma, which is also the remaining 1/6 or 15% of patients. Usually they present from 3 to 6 years of age, and they continue. Now, this is important because those epidemiological studies helped us as physicians to give us some predictor about the course of asthma. And this is one of the common questions you will face from the parents when you diagnose their child with asthma. They will ask you, is my child going to continue to have asthma as they grow up? And one of the good predictors is the asthma predictive index. And this is a clinical tool has been developed to predict for those children who was diagnosed with asthma early in life, whether they will continue to have asthma or they will outgrow it. And the asthma predictive index has 2 components. Major criteria and minor criteria, and to flag this index positive, you should have 1 or more major criteria, or 2 or more of the minor criteria. And so the major criteria include parental history of asthma, skin test positive to aeroallergens, eczema, which is a physician diagnosed atopic dermatitis. The minor criteria include eosinophilia in a blood test, having more than 4% of WBCs labeled as eosinophils, wheezing unrelated to colds in this age group, which is early in life at 3 years of age, or having allergic sensitization to milk, egg, or peanuts. So if the child has one major or two minor, what this asthma predictive index tells you is that this is a child who will continue to wheeze later on after the age of school. And so this is a very useful tool. Whenever you have a child with 4 or more wheezing episodes, one of them at least diagnosed by a physician with the criteria fulfilled, you can say with high predictability that the child will continue to have asthma as they grow. Actually, in some studies, 4 to 7-fold risk of wheezing at the school age. So this is really important. You can even identify those with positive asthma predictive index. And so you stress the importance of long-term follow-up. So if they have an asthma predictive index, that means they need really a close follow-up by a specialist or a physician. So we have mentioned this. Now moving to asthma treatment. Asthma treatment can be classified, and this has been updated in the most recent guidelines, in GINA guidelines, SINA guideline as well. So for the acute emergency management, we will go, you have to identify an asthma severity test, which is a clinical test. We utilize the PRAM score. And for the outpatient management, what was updated in our guideline is to include the asthma future risk management. And this is something was not stressed in the previous guidelines. So in the outpatient, you have to assess not only asthma control, which used to be the only thing to do in outpatient, you have to assess the asthma risk for adverse outcomes when you take the stepwise approach. Now going over those, so assessing the future risk, you have to cover 3 areas. Asthma attack within the next few months. So, and usually you can do this by looking for asthma uncontrolled symptoms, asking about the night symptoms, daytime symptoms, frequency, how frequent they use their bronchodilator. And also by reviewing the last winter season. And this is very useful information. Whenever you plan an outpatient management, especially for those dealing with patients moving from clinic to clinic, and you don't have long-term relationship with them, you have to ask the parents and the family, how did they do with the last winter or high risk season, whether it's winter or the spring season for those with atopic sensitization. The other one is the fixed airflow limitation. So even if they are asymptomatic, but they have features of mild airway, fixed obstruction in their airway, this is a risk factor that you have to identify and should have an impact on your stepwise approach, especially in the older children. And for fact, we know as pulmonologists, we have some cohort of patients, they walk to the clinic with spirometry FEV1 ranging between 60, 65, and 70, and they have nothing reported in their symptoms. So they have this marginal airway obstruction, and they just require a trigger to push them from that edge to have significant symptoms and might have also hospitalization. Medication side effect, and always you have to be checking for that, and namely the side effect of steroid use and the systemic steroid use. And because unfortunately you will face some parents avoiding inhalational steroid therapy because of the steroid side effect, but they end up using frequent systemic steroid and they end up with more side effects. And so education going to be very important in those patients. Now the stepwise approach is very simple. It's to maintain the control of asthma with the lowest step to minimize the cost and the side effect and to maximize the safety for your patient. So going quickly, I will be really flying so quick, and I will refer you to the reference online so you can access those information online. For the acute exacerbation, as I mentioned, the cornerstone. So for those of you dealing with patient in emergency, your priority is to classify the severity of asthma because it will make an impact on your management plan. Here, we are not focusing on asthma control to decide about a stepping up or stepping down treatment. You want to classify how severe their exacerbation, because you can decide whether they will be managed and sent home, or they will be managed and admitted to the floor, or they will be managed and admitted to the ICU. And this is the most important thing. So, because again, as we mentioned, BFT is not accessible for all pediatric patients. We rely on clinical approach, which is using one of the clinical validated clinical scores, and we utilize something called PRAM score, the Pediatric Respiratory Assessment Measure. And this measure is very sensitive and specific. It will make it standardized. So whether it is you or the educated nurse in your emergency room or your resident, you will be able to agree without subjectivity on more objective tool to classify your patient. It relies on the decrease of, it results in using those pathway, the Bram score, in decreasing the length of stay, decrease the bronchodilator use, and also it helps to minimize the adverse outcomes related to asthma management. The Bram score has several classifications. So that if they score 0 to 3, you classify them as low risk. We call it green zone, and the risk here is less than 10% that they would require hospitalization. If they score 4 to 7 from this score, it is moderate risk, orange risk. They have 10 to 50% risk to be hospitalized. And if they have a score from 8 to 12, they are red zone, and their chance to be hospitalized is more than 50%. So how you're gonna do it? We have it in our guidelines, in our brochure for SINA guidelines that I will share with you in a second. So it has 5 parameters: suprasternal retraction, scalene muscle retraction, airway entry, wheezing, and oxygen saturation. And based on what you have there, you can classify your patient from 0 to 3 based on their score, and then you calculate the total score. This is just to have an idea about the scalene features. There is an excellent video on YouTube. You can maybe search for it. You have a clear delineation. It's basically an accessory muscle. If it's contracted, it indicates severity in your respiratory muscle. It's a very sensitive clinical feature or sign. Now, looking to our acute asthma management in children, which was included in our SINA guideline, this is a brief look of what we have. And what we have, it might sound like a busy slide, but it has multiple components. We will go over those components. So the first component, which was up in the slide there, it just gives you a clear, easy, quick reference to Bram score. So you can do it bedside. So you will have it in the brochure, in your card. You can apply a quick scoring for your patient to identify what Bram score zone they will have, and the reference is there to classify them to mild, moderate, or severe exacerbation. And based on this classification, you can go to either pathway if they are green or orange or red. So again, due to the time limitation, I will not be able to go over this. Each one will give you a clear guideline on what you have to do in terms of assessment and plan. So this is there. Again, you can access this online, and even in a colorful format. I'm going to give you the reference at the end. And this is for the severe one. It includes, as you can see in the right side, the ICU management and recommendation to deal with those patients. Now, quickly for the outpatient management. Now, imagine your patient is coming stable in the clinic. Your role is not to assess their severity anymore. Your role is to assess the risk of asthma and how they are controlling their symptoms. So asthma control is the most important thing, and that's why you will go through initiation phase of asthma treatment, and then adjustment phase after they respond, and then maintenance phase. So again, for the asthma management in outpatient, the cornerstone is to assess the control. And we have adapted 2 assessment tools. One of them is called, which was also endorsed by the GINA guideline. So one of the tools to assess asthma control, it depends on the age group of patients. We have 2 tools. One of them is the track, which is used for the younger kids, and the childhood asthma control test for the older children. Again, those has been referenced in our guideline. You have both of them handy. You can apply them. This is the GINA criteria for asthma control. This is the very basic definition, has been used for a long time, and it has been proven to be very effective. So daytime symptoms, exercise limitation, frequency of bronchodilator use, and night symptoms should enable you to classify patients to have asthma under control, partially controlled, or uncontrolled asthma. Again, I will not go due to the time limitation with the asthma childhood asthma control test and the respiratory the track test. This is how it looked like in our brochure. So we have both referenced in our guideline. You have the track for the younger children, and then you have the stepwise approach, starting with the step 1 using bronchodilator as needed, and reaching step 5 using all of the steps, including systemic steroid. Always you have to challenge the diagnosis. Because again, one of the common mistakes for physician is to take asthma diagnosis granted. Never take asthma diagnosis granted. If this is not your patient, which is really a common practice, you deal most of the time with patient moving from clinic to clinic. And so if you have a patient coming to your clinic with their medication, asthma medication, if you don't know this patient with long relationship, don't take asthma diagnosis. You have to always challenge the diagnosis, and you have always to apply your clinical history and physical exam before you jump and adding more to their basket in their asthma management. So again, the same thing with the older children. You use the asthma control test. You go through the stepwise approach. As you can see, the systemic steroid has been added to it there. Also, anti-IgE medication, which need an asthma specialist or pulmonologist. And this is where you have to refer patients. Unfortunately, the laser is not working here. So there is also recommendation when to refer to a specialist for you as a general practitioner. So the last thing to just comment on, this is also included, as I mentioned, the asthma, childhood asthma control test and the track. Dr. Adil Harbi has covered most of the talk about the inhalational therapy and technique. My message to you that MDI, metered dose inhaler, is as effective as nebulizers. However, it has to be used with the proper airspace chamber, with the proper interface. So for younger kids who cannot control their breath through the mouth, you have to use the one with the mask. Whenever they can control their breathing through their mouth, typically 5 years and above, you should move to an aero chamber with a mouthpiece, because the deposition of the medication to the lungs will increase by 30 to 60%. And that will enable you to cut down the medication dose and the side effect. So asthma education is very integral. You have to include structured parent and patient education. Your role as physician is not only pharmacotherapy and prescription. You have to spend enough time educating the patient about the trigger, avoiding trigger, especially the cigarette smoking, shisha, and others, and also instructing them to identify the trigger, including other external factors, whether it is pets or home conditions and others. So asthma education is very integral. That also include side effect awareness. So treating the fear and anxiety about the systemic inhaled steroid and avoiding the medication because of those side effects. Now, asthma management has to include an action plan. And the target here is to enable the parents who spend more time with their kids than you to react to asthma changes. We know asthma is dynamic condition, so they have to be aware when to use and how frequent they should use the bronchodilator, when they should bring their patient to emergency, how to double or increase the dose of their controller therapy, and when to seek advice for their child. So this is an important aspect as well. So I know it has been a quick and long and very detailed information. That's why we have this free access through the Annals of Thoracic Medicine, the official journal of the Saudi Thoracic Society. We have been proudly being part of this great long document. There is an excellent section for pediatrics, and you can go, you will find most of the presentation of mine in those reference. I know the color is a little bit dark. The senagroup.org is the official also website of Sena Group. This presentation is available there. So please take the slides, make the awareness within your office and clinic, present what you have seen, and also share the information with every practitioner, nurses, and physician. At the end, I would like just to thank our group. I think I have summarized what I have mentioned just in the slide. This work has been really a great national teamwork. We would like to thank the big group of the Saudi Pediatric Pulmonology Association, led by my brother, Dr. Adil Harbi, and the great team. Also the Saudi Thoracic Society and our excellent international reviewer, who has empowered and improved our guidelines. And I will be happy to answer your question. Thank you so much for listening.
Thank you so much, Dr. Sami. And really, it's a great, and I know it's a very long topic. Needs more than one presentations. I think we have got some promise from our colleagues from AstraZeneca for future very good program only for pediatrics, because I don't want the pediatric topics to be at the end like this. It's not really representing the community. So thank you so much. And really, I'm sorry we cannot take any questions because this hall should be handled to the ladies for a wedding. They have a wedding, so I don't want them to come now. So sorry for that, and hope to see you, inshallah, in future meetings, which is coming soon. By the way, Pediatric Congress, it will be on February, late February. This is the Pediatric Pulmonary Congress. It will be on late 21 to 23rd of February. And don't forget tomorrow morning, at 10:30, there is a second day program. And to get to the CME, you should come and sign again. It's 12-hour CME, by the way. Thank you so much and see you tomorrow.